My name is John Goodman. I'm president of the National Center for Policy Analysis, and I want to welcome all of you here today. We're joined today by the representatives of the Heritage Foundation, the American Enterprise Institute, the Cato Institute, the American Action Network, and there are many other think tanks that are also with us in spirit that could not be here physically today, both on the right and on the left. And our interest is in the health reform bill that was passed last spring and in some major defects in that bill that we think are so serious and so severe that Congress will have to reopen the health care law and make major changes to it, even if there are no critics around. Now, I want to briefly go over 10 of those major problems in the bill, and then each of our speakers will address certain parts of it. Number one is an impossible mandate. All of us are going to be required to have a health insurance plan that is going to, the cost of which is going to be growing at twice the rate of growth of our income. And you don't have to be a mathematician or an economist to know that if you're forced to buy something, the cost of which is growing at twice the rate of growth of your income, eventually it's going to crowd out everything else that you are buying. Now, Barack Obama did not create this problem. This problem has been going on for 4 decades. For the last 40 years, healthcare costs have been growing at twice the rate of growth of our income. And the United States is not the worst case in the world. In fact, per capita real growth of healthcare costs in this country is right at, just a little bit under, the European average. So this is a problem for the entire developed world. But even though Barack Obama didn't create the problem, the bill that we passed makes it worse, because what it's going to do is going to lock us into that very unsustainable path. If we continue on the path indefinitely into the future, by about mid-century, today's young folks are going to reach the retirement age, and healthcare will have crowded out everything else that they consume. So when you reach the retirement age, you'll have nothing to wear, no place to live, nothing to eat, but you'll have really great healthcare. I assume that is not the goal that we all want to reach. The problem with the bill is that it takes away from the private sector many of the tools that are now there to allow you to control health insurance costs, limiting the package of benefits, more cost sharing. All that goes away, and we're more or less locked into a path that is unsustainable and undesirable. Then we have a bizarre system of subsidies. The hotel down the street has a lot of workers that are making only $15 an hour. They're the maids, the busboys, the custodial folks, the garden folks. According to the Congressional Budget Office, if these people make it over into the health insurance exchange that is going to be set up under the new health law, they will be able to acquire a health insurance plan for a family that costs $15,000, and the government will pay almost all the premium. Then if they have a lot of out-of-pocket costs, the government will reimburse them for those, and the CBO projects the total benefit that they will get is about $19,000. On the other hand, if these employees stay with the hotel and get their health insurance from that hotel, the only subsidy they get is the subsidy that's currently in the tax law, which means the ability of the hotel to pay premiums with untaxed dollars. But since people at this wage level don't pay income taxes, we're really only avoiding here the payroll tax. And the ability to do that is worth a little more than $2,000. So if Marriott provides the insurance, the subsidy is a little over $2,000. If you get over the exchange, they can have for free something worth $19,000. Where do you think people are going to end up? Well, the economist in me tells me that they're going to find their way into the exchange. And if the Marriott employees don't do it, but the other hotel employees do, Marriott's going to find it very hard to compete in the marketplace with labor costs that are 50% higher than all its competitors. I don't know what firms are going to do, but I can conceive of a world in which firms completely reorganize in order to take advantage of these new subsidies. The strange thing is that if Marriott has an employee that makes, say, $90,000 or $100,000, that employee gets no subsidy if he goes into the exchange. If he gets his health insurance from Marriott, however, Marriott again gets the subsidy that's now in the current tax law. the ability to pay premiums with pre-tax dollars, avoiding the payroll tax, but for the higher income employee, also state and local income taxes and the federal income tax. And those tax subsidies are about equal to almost half the cost of the insurance. So the higher income employee is going to want to get his insurance from the hotel. The lower income employee is going to want to be over in the exchange. What are employers going to do? Are they going to end their insurance plan for all the lower income employees and pay a fine? Or are they going to fire them and try to treat them as independent contractors or temporary workers? We don't yet know, but we know that they're going to be faced with a lot of very, very important decisions that are not going to be good for the job market. Not the kind of labor market situation that gives employers confidence they know what is going to happen. We have a health insurance exchange that creates perverse incentives for the insurers. If you charge everybody the same premium, regardless of health care costs, everybody's incentives are distorted. The person who has health problems and is going to look at the premiums and say, well, health insurance looks cheap to me, and they will tend to overinsure. The person who's healthy will look at those premiums and say, those are way too high, I'm going to underinsure. Over on the provider side, the incentives are even worse. The incentives for the plans are to avoid the sick and attract the healthy. Here in Washington at open season time in the late fall, what kinds of ads do you see in newspapers? You see ads of young, healthy people with children, and the implicit message is, if you look like the people in these ads, we want you in our plan. You're the people for us. But you won't see any ads saying if you have cancer or heart disease or AIDS or some other expensive-to-treat condition, consider us. Contrast that with the Allstate ads for auto insurance that you see on television. Remember the phrase, you're in good hands with Allstate? What kind of picture do they have? They have a catastrophic scene, something bad has really happened, and what Allstate is saying to you is, we know you don't care about auto insurance until you have an accident. But then when the really bad thing happens, they're saying, we'll take care of you. In health care, however, it's the other way around. We're giving insurance companies an incentive to attract the healthy and say to the sick or the potentially sick, we hope you don't get sick at all, and if you are, we hope you'll go someplace else. This is like going to a restaurant that you know in advance doesn't want you. You don't want to erect a health care system in which insurers have an incentive to avoid people who have problems. And we already have a model, by the way, where this works so much better, and it is the Medicare Advantage program, where we have special needs insurance plans that actually go out and try to recruit senior citizens with high health care costs because they know they're going to get a premium that's much higher than the premium paid for everyone else. We have in this law perverse incentives for individuals. We have a fine for being uninsured, which is, quite frankly, not nearly great enough if you want to make the premium completely independent of people's expected health care costs. In Massachusetts today, people are going bare while they're healthy and signing up for health insurance after they get sick. The number of people who do that is increasing each year. Small problem for Massachusetts right now, but it would be a huge problem for Texas, where at Parkland Hospital in Dallas, they sign Medicaid patients up in the emergency room. Doesn't matter that much for Medicaid because it's taxpayer funded anyway. Taxpayers end up paying the cost of the care whether they sign up or they don't sign up. But if you can sign up Blue Cross patients in the emergency room, Blue Cross isn't going to survive very long in the health insurance marketplace. We have made promises that we can't possibly keep. According to Congressional Budget Office estimates, we're going to insure about 32 million people who would otherwise be uninsured. If the economic estimates are correct, those people go out and try to double the amount of health care that they have been consuming. We have millions of people, 90 million on last estimate, that will have access to preventive care with no deductible and no copayment, benefits that they didn't previously have. Now, to give you some idea of how bad that is, economists at Duke University estimated what would happen if everybody in America went out and got all of the preventive care that is recommended by the Preventive Care Task Force that's going to set the standard for the new health plans. And their estimate was that the average primary care physician in the United States would have to work more than 7 hours every working day to provide these services, essentially providing services to mainly healthy people, leaving very little time left over to take care of the sick. Now, what I'm describing is a huge increase in the demand for care. But in this legislation, we did little or nothing about the supply. Now, early on, there were versions of the bill that had line item expenditures to produce more doctors, more nurses, and so forth. But all of that was zeroed out on final passage, probably to keep the cost of the legislation down. The CBO guys probably figured that, well, if we don't have any more doctors, they can't deliver more care, therefore we can't spend more money. But in any event, what we're having now, what we're going to have, is a large increase in demand, no change in supply. That's a huge rationing problem. In this country, as in other countries, we don't primarily pay for care with money, we pay with time. So the time price of care is going to go up everywhere, at every emergency room, at every primary care physician's office, at the offices of most specialists. And in that kind of environment, it's not going to be good if you're in one of the plans that pays below market rates. So if you're elderly or disabled on Medicare, or if you're on Medicaid, or in Massachusetts, a lot of the plans that are subsidized also pay really low rates. So if you're in one of those plans, you're going to be less preferred. You're going to be at the end of the rationing lines. And one of the really strange things about this legislation is that most people in Congress who voted for it were left of center. But what's going to happen, in my opinion, is a redistribution of benefits from low-income to higher-income people. This bill forces middle and higher-income people to have more generous health insurance than they wanted. But once they've got it, they're going to act on it. And when they do, they're going to crowd out the poor, the elderly, and the disabled. The most vulnerable parts of society are going to have an increasing problem of access to care. Seniors in particular are going to have a difficult problem because we have in this legislation a requirement that we cut payments to doctors and hospitals well below what the private sector is paying, and that gap grows over time. So that according to the Medicare actuaries, by the end of this decade, Medicare will be paying lower rates than Medicaid for poor people. Now, in most places, including the city where I live, Medicaid patients have real difficulty finding doctors who will see them. And all too often, they're going to community health centers and to safety net hospitals for their care. The elderly may be there as well, and if Medicare payments drop below Medicaid, the elderly may be behind low-income families in getting their care. There are large burdens here for the states that will be difficult for them to meet, and I suspect they will respond by trying to game the system. This legislation does nothing to solve the problem of portability, which is the biggest problem that most people have. There's nothing in the legislation which creates truly personal and portable health insurance. And finally, this legislation overregulates both the patients and the doctors. If we really want to solve healthcare problems, if we want to get rid of waste in the system, if we want higher quality care, then we need patients and doctors who ferret out waste and get rid of it. But they're not going to do that unless they have incentives to do so. The current system gives them no incentives. The new system is going to make those incentives even worse. What we need to do, if we want a lower cost, higher quality healthcare system, is make it in the self-interest of every patient, every doctor, every nurse, every hospital administrator to do just that, lower cost and raise quality. Now I want to turn the program over to my colleagues. This program is, by the way, co-sponsored by the Heritage Foundation, and Robert Moffat, who's here today, was very kind to help us put this program together. But the first speaker I want to turn to is Douglas Holtz-Eakin, who used to be the director of the Congressional Budget Office, and he is currently the president of the American Action Forum. And Doug, will you come to the podium? Let's give him a hand.
Well, thank you very much for the chance to be here today and for throwing this event. Obviously, this is a central piece of legislation and one that ought to be examined very closely. I want to echo the remarks that John made about the impacts of the law from the perspective of health policy. But I was taught that when one looks at legislation, you should also look at it in the context of the nation's problems. And the top two problems the nation faces today are an economy that is badly underperforming in the need to generate jobs for Americans, and a federal budget outlook which is in and of itself so threatening as to really cast in doubt the future prosperity and freedom of Americans. And this legislation is quite damaging from those perspectives. First of all, the healthcare sector is now 1/6, moving toward 1/5 of the economy, and everything that John said about improving incentives in that sector would constitute improved economic policy, getting higher quality in care for less cost, improvements in efficiency are things that we ought to support as a matter of economic policy in the United States, the healthcare objectives notwithstanding. On top of that, there are spillovers to the rest of the economy. And if you look at the law, it promises to raise $500 billion worth of taxes over the next 10 years. And I don't think there's anyone in this room who, when asked, gee, if you want to create jobs, should we raise $500 billion in taxes over the next 10 years? I don't think you're getting an answer of yes out of anyone. That is in and of itself a strike of substantial proportions against this legislation. Some of those taxes will show up in the form of reduced incentives. There's a so-called Medicare tax, a surtax on investment income for high-income Americans. It's a pure increase in marginal tax rates. Has nothing to do with Medicare. It's just an increase in taxes that will damage exactly the same kinds of entities that were the subject of so much discussion in the recent debate over extending the 2001 and 2003 tax laws. These are the small businesses and the entrepreneurs in America who will ultimately create new firms and generate job growth. Embedded in this bill are damaging incentives for those individuals. There are taxes on medical devices, on insurance companies, on all sorts of inputs into health services that will lead to higher costs for those services. When health services are more expensive, health insurance will become more expensive. We'll see premiums rise, both because of the costs and because of the taxes on health insurance companies. And when those premiums get more expensive, you'll see that bottom line show up in every small business in America. Every businessman will have to do the calculation that says, I've got to pay my workers less to cover the cost of the premium increases that I'm seeing. Every worker, as a result, will bear the cost of this bill. There will be some workers, those in particular at minimum wages, where you can't lower their cash to offset the increase in premiums, and we're going to see those jobs just go away. So again, it's going to be the low-income workers who are primarily damaged by this bill and the economic incentives that are in it. This is a recipe for less jobs in America. It's a recipe for slower economic growth. Now, that's just putting the $500 billion of taxes in. Now, if you layer $1 trillion in spending on top, certainly that'll make things better, right? Well, I don't think so. There's nothing about sending out checks for $1 trillion worth of subsidies that's going to generate job growth in the United States. Nothing about that has ever been a successful path to improved economic performance. And I believe that the nature of those subsidies, I want to echo what John said, in addition to the real efficiency costs and the growth impacts of this bill, there's some deep unfairness associated with the way these subsidies are distributed. All right? The example that he gave is a very real one. You have two people who are otherwise identical, go forward to say 2016, and you got one woman making $70,000, gets her insurance from her employer and gets only the tax benefit from the employer-sponsored insurance. Another woman making $70,000 goes to the exchanges, gets $7,000 in federal subsidies. That's an inequity that's so profound that I don't believe it will be allowed to persist. And one of the things I'm deeply nervous about is that a future Congress will fix that inequity by giving everybody $7,000 and thereby making the bottom line cost of this bill so much more expensive than it already is. And I want to turn to the budgetary implications because they're very closely related to my concerns about the economic incentives. There are many ways to look at the budgetary implications, but the one I would just ask you to begin with is the simplest one. It's the laugh test. Set up two new open-ended entitlement programs that will grow at 8% a year, CBO's estimate, as far as the eye can see. 8% a year is faster than the economy is going to grow. It's faster than any notion of revenues will grow. So we're going to set up two new programs that will grow faster than the economy for as far as the eye can see, and we are supposed to believe that it reduces the deficit. It is impossible to make that claim with a straight face. Now, we have CBO estimates of budgetary impacts which show deficit reduction from the bill. But I think it's now widely understood that those particular estimates are flawed by the nature of the rules under which CBO is forced to operate. And that when you tell CBO that you're going to pretend that an inequity as large as the one I described will last forever, they have to take it at face value. When you tell CBO, we're going to cut money out of Medicare year after year after year, having done nothing to change the basic economic model under which Medicare services are produced, and thus somehow have a miracle occur, they have to assume that's true. But if you take away those rules and look at this in any realistic fashion, our estimates have been that the bill would increase the deficit by $500 billion the first 10 years and $1.5 trillion in the second 10 years. That's a really important thing from both the future of the economy and a fairness perspective. The reason this bill is so offensive, in my view, from a fairness perspective, has to do with every one of the young people in this audience. This bill is the biggest intergenerational money grab in history. It forces every young American to buy insurance and thereby pay for the costs of those who are older and sicker than them. And then, having done that, when they get to the end of their working careers, they will inherit the debt, the trillions of dollars of debt that this bill will produce, and be saddled with paying that off as well. From any perspective of fairness, that's simply wrong. And it comes at a time when it is also dangerous. Everyone's heard a lot about the budget outlook. Let me just say this. Regardless of which one of the particular forecasts you look at, the United States is in a fiscal situation that is unprecedented in its history. Over the next 10 years, we are likely to run deficits that average nearly $1 trillion by the end and average over $600 billion every year. At the end of 10 years, we'll be running $1 trillion deficit. $900 billion of it will be borrowing, interest on previous borrowing. So we'll be in the position where we're borrowing just to pay for the interest. That's a recipe for financial disaster. Along that path, we will meet the technical criteria for downgrade as a sovereign borrower. That was the fiscal outlook before we passed this legislation. This legislation will make it worse. And I stipulate that introducing a damaging bill to a dangerous fiscal situation is not going to generate jobs. So we've got a package here which is damaging from every perspective and very hard to support. Thank you.
Very good. Thank you, Doug. Thomas Miller is a former senior health economist for the Joint Economic Committee. He is now with the American Enterprise Institute. If you're interested in health policy and you go on the internet and you look at the journals, it's hard not to find Tom Miller everywhere you look. Let's give him a warm hand.
Thank you very much, John. There's a lot of repeal and replace work to be done, and I've got some other material outside on many of those other issues. You can find them also at www.aei.org/ and you should slash it, repeal and replace. Coming soon also with my co-author Bob Moffett, Jim Capretta, and Grace Marie Turner, Why Obamacare is Wrong for America. HarperCollins, March 22nd, anniversary time. Look for it. But today, John asked me to focus on something else, how to improve the healthcare delivery system and healthcare quality through less political and governmental ways and means. Well, first of all, we have to change how we define and talk about the issue. The two key measures should be health outcomes and value. Healthcare quality too commonly is viewed in process terms or as how to execute a predictable, less flawed, somewhat more efficient manufacturing process instead of a personal balancing act in determining the best combination of cost and quality for which you as a consumer, a patient, a third-party payer, or a taxpayer subsidizer of health are actually willing to pay. There's no single setting that's either just right or even unquestionably adequate for everyone. That doesn't mean there aren't some institutional process no-brainers we don't need to clean up along the way, but that's just not the big story on how to get better value. We also need to reach beyond the conventional health care delivery system per se because a wide range of factors and actors shape our health. That means looking beyond our myopic bias toward dwelling almost exclusively in most health policy debates on healthcare financing, health insurance costs and access, and official benefits coverage, and then then fighting over the political flow of dollars without considering what they actually achieve in terms of better health outcomes at lower costs. Two different individuals can have exactly the same health insurance, and their actual differences in health, both initially and even after getting the same diagnosis, can be vastly different depending on where and how and who they go to for treatment, how they make decisions as patients, and a host of other factors earlier in their life that brought them to that particular point. We always forget to look for the health outcome keys that are lost further away from the healthcare funding lamppost. So let's first be much more humble about promising simple guaranteed answers, but particularly through the distorting, evidence-free mechanism of national healthcare politics. The Patient Protection and Affordable Care Act is only the latest, though perhaps the worst incarnation of promising what's unbelievable and delivering what's sadly all too predictable. In the flyover land of the law, devoted to the unicorns of future health delivery reform miracles or science fair projects that never got out of the exhibition hall, we essentially have various new iterations of repackaged, centralized command and control edicts from the usual sources who issued the previous ones that either failed outright and aggravated the system's pre-existing chronic conditions. So the latest establishment cliche is that just about every idea for controlling healthcare costs and improving quality is in the law. Well, it's true that just about every bad idea made its way in there, because who really reads that stuff anyway? Certainly not members of Congress. But they managed to leave out a few important ideas, like choice, competition, personal responsibility, truth in labeling, market pricing, respect for personal preferences, incentives for better performance and decision-making, double-entry bookkeeping, and even arithmetic. So most of the healthcare quality experts are trying to sell a message, moreover, that most Americans don't want to hear and don't believe. Yes, we complain a lot about healthcare costs that are too much, even though we usually only see a fraction of the full expense directly, or that there are too many other barriers in the way to getting more of what we want when we want it. But a vast majority actually think the health care they receive is excellent or good. Just look at the Gallup poll's most recent health and healthcare survey from last November. So that's partly why you will hear politicians talk a lot more in public about high health care costs or expanding coverage of the uninsured than pointing proudly to the Patient Protection Affordable Care Act's health care delivery provisions. The less exciting reality is that our health care system, though excellent in many important ways, is not perfect, and some very different approaches could improve its value balance, its consistency, its consumer friendliness, its accountability, and with some more honest choices, push forward in a more competitive and transparent marketplace its real, unsubsidized affordability. The meter's running on my time, so here's the simplified menu. First, throttle back a good bit of the overbearing counterproductive regulation that gets between the needs and resources of patients and the capabilities of healthcare providers. 2, guarantee a socially acceptable floor of healthcare services for the less fortunate, but stop pretending to subsidize so much of everyone else's bills when it mostly becomes more wasteful rounds of dollar trading through clogged political filters. 3, stop pretending that all care must, let alone can, be high quality and provided equally to everyone all the time. Instead, let's encourage more competition in seeking and delivering care whose value continues to improve from wherever it is at the moment. To do that, we can't just imagine the miracles of a totally unfettered free market, although a freer one will help. We'll have to rely very, very carefully on some public policy changes that can help private parties compete in measuring and reporting better how different parts and parties in the healthcare system perform so that they can then be rewarded differently for doing much better or at least not doing as badly as before. I've written about this in greater length elsewhere, and the new health law is not totally moronic about this in terms of developing some preliminary infrastructure that's called faint praise, but it remains far too fixated on a lengthy, politically determined set of consensus standards that by the time they're derived will be either too weak, too unrealistic, or too outdated, and perhaps all three at the same time. While other provisions in this law drive us toward a more concentrated healthcare marketplace that is less competitive but more politically dependent. So the short alternative version is patients, providers, and other payers all need better information, not more information. We can't expect it to be perfect. We can't measure everything, or maybe not even most things, but we should use what is the best available within limits of current data and measures while acknowledging those limitations, and then just try to shut up about quality when we really don't know one way or the other. Then just check the all-in costs, decide what you really want to save or waste your money on, or pay for some other dimension of patient experience. We need information much more about provider performance than about insurers and the insurance they offer, and about physicians, not always at the group level, and particularly more so than about big box hospitals, which vary within them. The information needs to be a combination of measurable health outcomes or intermediate markers for them, and the all-in cost of the relevant episode of care. It's the value combination that matters, not just quality, cost, or price alone, but other subjective preferences are important as well in terms of patient experience. This whole area is complicated, contentious, evolutionary, and full of cautions and caveats, but we ignore it at our peril without beginning to engage it. So let's have some competition in what matters in healthcare that comes outside of government channels. There's some basics we have to do to aggregate data and measure it, but then we have to allow it to be accessible to other parties to determine what actually matters. Thank you.
Thank you, Tom. Michael Cannon is Director of Health Policy Studies at the Cato Institute. Some months back, he recruited a University of Chicago professor to show us how we really ought to be handling the problem of pre-existing conditions. We had a really lively discussion of it at my blog, the John Goodman Health Policy blog, and I've asked him to tell you about it today. Please welcome Michael Cannon.
Thank you, John, and thank you all for coming. I may have to leave before the question and answer period, so if anyone has any further questions about my remarks, I want to encourage you to visit the Cato Institute's website, www.cato.org. You may have heard today that the Department of Health and Human Services released a study that said about half of non-elderly Americans have a pre-existing condition, and that repealing the health care law known as Obamacare would mean that those folks would have trouble getting coverage. But Obamacare, they tell us, would guarantee that those folks would get coverage and get the care that they need. There are a couple of problems with that study and these claims. The first one is that a government survey conducted just a few years ago found that only 1% of Americans had ever been turned down for health insurance, and that's consistent with other research. Research by the Rand Corporation that looked at lightly regulated individual insurance markets, such as California's, found that lots of people with pre-existing conditions get insurance, even when the insurance company has the ability to deny them coverage or to charge them higher premiums. It's a tricky thing, really, to get people to keep the promises that they make to sick people. And this is true whether you're talking about public health insurance programs, private health insurance. But let's look at the record. In the 1940s, the federal government backed a horse that doesn't even make a promise, a long-term promise to sick people. I'm talking about employer-sponsored health insurance. And if you know the history of employer-sponsored health insurance in the United States, you know that this market is a creation of government. In the 1940s, the government, through a series of accidents, decided that employer-sponsored health insurance would be exempt from payroll taxes and income taxes, which creates a huge tax break for employer-sponsored health insurance, such that, and a corresponding penalty if you want to purchase health insurance on your own, such that if you want to purchase health insurance on your own, it can cost some people twice as much for the same or less coverage compared to getting that through an employer. This is the horse that the government decided to back, but you'll notice, if you think about it, your insurance plan that you get through your employer does not provide you a long-term promise to take care of you when you're sick. They only promise you to provide you medical care so long as you are still connected to that employer. If you get sick and cannot work, then you lose that health insurance and you are on your own. In the individual health insurance market, researchers have found, even when only when very lightly regulated, provides more secure health insurance than employer-sponsored insurance. For people with high-cost illnesses, they are as likely or more likely to keep their health insurance and not end up uninsured than if they have insurance through an employer. So That's the situation that the government created when it decided that it would make increased access to health insurance. It shunted 9 out of 10 people with private health insurance into this employer-sponsored health insurance market where you don't even have a guarantee from an insurance company that they'll take care of you over the course of a long-term illness. How about another government solution? Well, we've heard a little bit about this one today. That's the Medicare program. About 20 years later, the government decided we're going to provide secure health insurance to people in old age. So they created the Medicare program for people over age 65. Well, yes, Medicare does provide secure access to health insurance for the time being. They do it in part by, Medicare does so in part by being completely fiscally unsustainable. There's no way that we can keep providing access to the type of medical care that seniors have been accessing in Medicare for the past decades. In addition to that, one of the ways that Medicare is so financially unsustainable is that 1/3 of Medicare spending goes toward care that doesn't provide any value whatsoever, doesn't make the patients any healthier or happier, is what research from the Dartmouth Atlas tells us. And along the way, Medicare causes most of the serious quality problems that we see in the U.S. healthcare sector. The problems of uncoordinated care, the problems of medical errors, that cause tens of thousands of fatalities each year. The problems of a lack of electronic medical records and other health information technologies, a lack of comparative effectiveness research. Medicare is at the root of all of these problems. Now, Obamacare's solution to this thorny problem of how do we get people, how do we keep the promises that we've made to sick people, is essentially government price controls. When they talk about eliminating discrimination against people with pre-existing conditions, what they mean is they're telling insurance companies, we don't care if this patient would cost $50,000 to insure. You can only charge them $10,000, the average premium. That doesn't eliminate discrimination against people with high-cost conditions. All that does is it creates a $40,000 incentive for insurers to find other ways to discriminate against those patients, to deny them care, to avoid, dump, or mistreat them so that they will leave that insurance company's books and go to another competing insurance company and bring down that insurer's bottom line. This sort of thing happens wherever we see these Obamacare-style government price controls. It happens in states like New York that have had these price controls on the books for a long time. It happens in the Federal Employees Health Benefits Program, where many of the people here probably get their health insurance, which actually operates under the same sort of price controls as Obamacare. This sort of discrimination will reach you whether you are rich, poor, or anywhere in between. One half is instead of what the HHS tells us in their report today, one half is actually the share of non-elderly Americans who would be hurt immediately by Obamacare's price controls, and 100% is the share of people who would be hurt over time by these price controls. Again, this is a thorny problem. How do we keep the commitments that we've made to the sick? Lightly regulated markets are doing a better job of providing secure health insurance and at a lower cost than any of the solutions the government has put forward to date. And they can do even more through innovations that give patients a total satisfaction guarantee, that say to patients that even if you get sick, you will have the freedom to switch insurers and the resources to do so if your current insurer tries to skimp on coverage or care, if it doesn't keep its promises to you when you get sick. But this innovation and other innovations are going to be impossible. Other innovations that we cannot even foresee are going to be impossible so long as Obamacare and its government price controls remain on the books. Thank you very much.
Robert Moffitt is Senior Fellow at the Center for Policy Innovation at the Heritage Foundation. He's been involved in the healthcare field for as long as any of us can remember, and he is a tireless worker. Let me tell you, if you email him at night and on the weekend, he'll probably answer you. I think he never quits working. Let's give a warm welcome to Bob Moffitt.
Thank you very much, John. Ladies and gentlemen, there's a lot of work to do. We're faced with a great task in front of us. We're now entering really what amounts to today and tomorrow, the second phase of the great national health care debate that is going to go on for quite some time. Let me focus on just a couple of items related to one of the most important issues facing the country, which of course is the challenge of entitlements. And at the heart of that is the challenge of the Medicare problem, Medicare issue. This is January 2011. So this year, the first great wave of the baby boomers turned 65. And over the next 18 to 20 years, Medicare is going to experience the largest single demand for medical services. Probably we will see something that we have never seen before in terms of the tremendous demand for medical services in the Medicare program. The size of Medicare will double in the next 20 years, really. At the same time, as you all know, it's all public knowledge. Nobody disputes it. We are faced with a potentially critical shortage of physicians. Not only primary care physicians, but geriatricians as well. The law acknowledges this and starts to pay physicians more in certain underserved areas. But the gravity of this is greater than most of us, gravity of this is greater, I think, than most members of Congress really appreciate. And indeed, one of the striking facts about this debate has been the hostility, collectively, of the medical profession. Forget the representatives of the medical profession or the lobbyists for medical professionals. The medical profession itself, the hostility of the medical profession to this law. And there's a reason for that. American doctors are becoming demoralized. And they're demoralized because more and more of them recognize they do not have control over their professional life. They are more governed by regulation. They are faced with an expansion of government payment. And most of the problems that bother them, including medical malpractice problems, have not been properly addressed. But getting back to Medicare, there's something else that is remarkable here. While we're seeing this massive expansion in coverage, and at the same time a tremendous addition in public cost in health care, Medicare is at the same time simultaneously undertaking record-breaking reductions in payment to doctors and hospitals and other medical professionals. The Center for Medicare and Medicaid Service says that this is going to result in a savings of $575 billion in the initial 10 years of the law. What does this actually mean? We've never actually been here before with a tremendous demand for medical services among a large and growing aging population and such a significant reduction in Medicare payment. But absent Medicare reform, the payment reductions of this magnitude will threaten seniors' access to care. Depend on it. That is not my point of view. That is the view of the actuary of the Center for Medicare, the actuary of the Office for the Centers of Medicare and Medicaid Services. And absent further legislative intervention, the projected Medicare savings will not enhance the solvency of the program. Indeed, there was a wonderful letter addressed to Senator Jeff Sessions of Alabama by Doug Elmendorf, January 22nd of last year, 2010, where he said, the unified budget accounting shows that the majority of the HI Trust Fund savings under the PPACA would be used to pay for other spending and therefore would not enhance the ability of the government to pay for future Medicare benefits, end quote. And without an escape valve for senior citizens, the provisions of the law are going to guarantee that we are going to see greater access problems over time. The CMS actuary does not think, in fact, that these massive record-breaking Medicare reductions will actually survive. But in any event, if we actually were to go down this road, you certainly want to have access for senior citizens to private sector options that many of them do not have today. It doesn't make sense to cut, for example, Medicare Advantage by $136 billion and reduce their access to those private plans, or to maintain the existing limitation on senior citizens' ability to go outside of the Medicare program and contract privately for medical services that they need. We have to go in a very different direction. Ladies and gentlemen, we are entering, as I said, today and tomorrow, the second phase of this great national debate. But one thing that we ought to keep in mind is Congress has direct responsibility as the board of directors for one of the largest programs, the Medicare program, and they have got to figure out a way to get this financial house in order. Right now, Medicare has an unfunded liability of over $30 trillion. Please tell me, is there any member of Congress who knows right now how we are going to handle this financial challenge? Does anybody know? The truth of the matter is, nobody knows. But we are faced with this. And many of you are young people, and you will, in fact, pay the price for inaction in this area. There is a way out. We have to think about restructuring Medicare, changing it from the existing open-ended entitlement that exists today to a program which, in fact, is based on real competitive insurance and tie premiums and adjust premiums and subsidies in the Medicare program to income, to get away from what we have today, which is so costly. We should provide the beneficiaries with a wide range of choice in health care plans and options, and at the same time make sure that in a future Medicare system that we will expand access to physicians and reduce the number of physicians who say that they refuse to take Medicare patients or accept new Medicare patients. There are ways to do this. My own view is that many of you are enrolled in a program which is actually quite good in terms of organizing health insurance benefits, the Federal Employee Health Benefits Program. But the key element of it is driven by two free market principles, consumer choice and direct competition. Many of you can do what many Americans cannot do, and that is if you are dissatisfied with your health insurance package, you can fire your health insurance plan. That's not a bad option. It's not a bad option for the future of our senior citizens as well. They are going to have to depend upon us to make good decisions to give them access to the quality of care that they deserve. Thank you very much, ladies and gentlemen.
Thank you, Bob. That was very informative and very good. Now I want to open up the floor for questions, and if you will tell us who you're directing your question to. Let's have a hand up. Well, let me just begin by asking this question. Do the panelists believe that senior citizens realize what has happened to them under this legislation? And what do you think will happen with the Medicare provisions? Will we go forward? Will we carry it out the way the law is written? Or will it have to be changed? Who wants to take this one?
I'll go first.
All right.
I thought that it was very interesting that both the actuary at CMS and the director of the Congressional Budget Office both publicly stated in formal official correspondence to the congressional leadership that they did not think that the Medicare payment reductions were sustainable over time, both the CBO and the CMS actuary. We have never really quite gone here before at this level of payment reductions. So I think that whether this survives or not, I think it's highly unlikely in my view that these kinds of reductions will survive.
Well, let me address this question to Doug Holtz-Eakin. What happens when you have a bill with a huge expense and the way you thought you're going to pay for it doesn't pan out?
Nothing good. This has been the history of entitlement programs in the United States. They are launched with fanfare that includes their budgetary soundness. Over time, enrollments expand beyond what was originally envisioned. Benefits are added to what was originally envisioned. The incentives are such that no one is ever going to impose things on programs that cause the beneficiaries to scrimp or save. That wasn't the point. And so we get these enormously bloated entitlement programs. That's been the history in Medicare, history in Medicaid. It is likely to be the future of this law unless we change course. So we end up where we are today with enormous structural deficits that are so large and so troubling that they literally threaten the capacity of the U.S. economy to provide a higher standard of living in the future than we have now. And that is something we simply cannot do.
John, we devalue currencies when we have economic imbalances. We can also devalue health care, either explicitly or indirectly.
Yes, sir.
Michael Cannon mentioned the Dartmouth research that suggests that about 30% of the spending in Medicare is fat. It's wasteful. It goes to it's spent on care that provides no particular good to the people it's being spent on. So my first question is, doesn't that suggest that there is, in fact, a lot of fat to be pulled out of Medicare? And if so, how do we do that? And then my second question is sort of following on that. I don't know if you all saw the Health Affairs study that was published last month looking at McAllen and El Paso, Texas, and looking at variations in Medicare spending, and they found that versus variations in private spending, they found that the variations that exist in Medicare spending don't seem to exist in private spending, at least in those two locations. My understanding is that the administration, that a lot of the plans for Obamacare were based on the idea that the same sort of fat existed in private insurance and in private health insurance. So what does this suggest about the future for the law, about reform, and about how it's going to play out?
Well, the fat is measured crudely as an aggregate. It's certainly true. This actually was known 15 years ago. People are rediscovering it, that there's less variation in private sector healthcare than there is in Medicare. There was an older study in the mid-90s which looked at the FEHB program with managed care plans where there was less variation on a regional basis. But, you know, the tendency of researchers, it's the bias of the field, is you go where the data is. And we had Medicare data, and you could show this type of crude variance, and then you would concoct a lot of theories around it. It could be true that the nature of the Medicare program lends itself to more of that waste and variation without actually measurable elements. There are two principal ingredients to dealing with this where we're not ready to go there first. Put the money in the hands of the patients and the consumers. Who's the only person who would see both the costs and the value of what they receive and the person who actually receives the care? Well, we've got that pretty much distorted. And the second is we do need some type of, even though they're imperfect, markers as to what's better, what's worse most of the time, not perfect to know something in that regard. We're building a lot of metrics which may not tell us that, but that's at least the general direction in which to go. Is there waste? Yes. Can you find it right here on the map in this particular area and pinpoint it and get that passed politically? Probably not. So we might have to decentralize that set of equations.
Yeah, let me just add one thing to that, and Tom's answer was very good. There probably is 30% waste in Medicare. Maybe there's more than 30% waste, but when you get a hospital bill, it doesn't say on the bill, these items are waste, right? If it did, it'd be easy to get rid of the waste. The problem is that you don't know where the waste is. And what we really mean when we say there's waste is that some bright entrepreneur, really efficient hospital administrator, really efficient group of doctors could have done this for 70% of the cost that was actually expended. But unless they have an incentive to go do it, they're not going to do it. So we're not going to get rid of waste unless it's in someone's self-interest to go do it. Yes, sir.
Do you believe that the new Congress should even attempt to fix this legislation? Do you think that it's possible to fix this law? Or do you think that tweaks as a whole really can't make a difference? The whole thing has to go.
Do any of you want to answer that?
I'll take a shot at it. I think that the issue here is, what is your vision for the future of healthcare in America? And what I think the law represents is it represents a very specific vision of healthcare policy. We know our colleagues very well who disagree with us, and frankly, this is their vision of what the healthcare system should look like. They believe, many of them very strongly, that health insurance plans should be public utilities and should be very heavily regulated by the federal government. And the federal government should make the key decisions in allocating resources in the healthcare system and making decisions about what will be covered and how it will be financed. Now, that's not my view, and I think my colleagues here share my views on this. But the bill does represent that point of view. Now, having said that, I would say that, in answer to your question, that you actually cannot build a system based on free market principles of consumer choice and competition on a foundation which is fundamentally incompatible with that vision. A foundation which is built primarily on central planning and bureaucratic regulation. Again, that is not a personal opinion. That's what the law does. And I understand, our friends on the other side, they have a very different vision on this. Let me just make one observation before I stop. In the early 2000s, the idea of a health insurance exchange became very popular among health policy analysts. The idea behind that was competition among private health care plans. Alan Enthoven, for example, had written on this issue. But at the University of California, a number of analysts got together and they said, look, this is a great idea. What we should do is we should have a health insurance exchange with a taxpayer-financed public option. And what was the purpose of it? Well, it was very, very open, very, very publicly celebrated. It was a way to get to a single-payer healthcare system by basically undercutting private health insurance. That's the image. That's the vision. We have a different one.
This was a package deal. It was not all you can eat, it was all you can stomach before regurgitating. And you can always talk about a few appetizers, which seem tasty. The problem is you have to have the entire meal. So in the same way that pulling one part out of this means that the rest has to go with it as well, you can't just say, I'll have one of column A and one of column B and don't worry about the rest in that regard. The danger, though, in pulling apart the most obnoxious features is we're in a game playing for time. And the designers of this legislation want to institutionalize and make inevitable the early seeds that are growing further and further and buying off a lot of the healthcare industry in that regard. That's why this whole thing has to be pulled up quickly, and we need to get right away then onto what we need in its place. It doesn't mean nothing remains. It means we have to then find some things that make sense after we first pull up the weeds.
This is just for the entire panel. After the repeal vote, the House is set to vote on a resolution that sets out a list of goals. Are you guys confident that that list of goals directing committees to come up with replacement legislation will make the serious structural changes you're talking about to the Medicare program or how healthcare is paid for?
I think there's good reason to be optimistic on that front. What people now forget, given the events of the past 2 years, is that if we dial the clock back to the beginning of the healthcare reform debate in the United States, there was a tremendous amount of bipartisan consensus about the need for reform. There was a tremendous amount of consensus about what reform should look like, how it should provide incentives to root out low-value care, decentralize and equalize across the states these sort of cost differences that we've seen, provide people with better insurance options. None of that was in dispute. So there's no reason to be at all skeptical about the notion that you could go out and find common objectives. It was also the case that there was a tremendous amount of bipartisan agreement on a lot of the delivery system reforms that would improve the quality of care in the United States. Where there was great disagreement was in the nature of the insurance reforms and how to cover more people. And this legislation is by and large about the latter at the expense of the former. And so we could go back and do much better on a bipartisan basis by concentrating on the real problem, which is the U.S. delivery system, and not a massive expansion of check writing capacity at the federal level to cover people in bad insurance markets.
Yes, sir.
Given the likelihood that there's going to be political gridlock in terms of repealing the law at least over the next 2 years, and that there's going to be a lot of forward movement at the state level with creating the exchanges as they look forward to 2014, does it make sense for one state or multiple states to try experimenting? I think the law provides for some of the models that you've outlined here, like, for instance, a competing FEHBPP model at the state level that would even allow not just private insurers, but also Medicare to participate in that.
The law doesn't allow enough of that experimentation. States are going to have to be more aggressive than what are going to be the rules sent down from HHS. There's some leeway, but you get into this plea bargaining game where you say, give me just a little more slack. Can I have a few more minutes out in the prison yard for exercise time? And it doesn't actually turn it around. I'll be speaking tomorrow at the National Congress on Health Insurance Reform. There's a different way to do exchanges, and to some extent, states have to put something on the ground which isn't going to fit exactly in the parameters of what they're told from Washington to do. They need to get some of those examples that actually work in the next 2 years, and then see what we actually prefer. Something that works at the state level, that makes sense to the people who live there, or what the rules have been concocted for an entirely different regulatory scheme, which is not where we need to go.
The only thing I would add to that is that the administration seems very desperate to me to get something to work. And I think that's why they gave waivers to 1 million workers, including 30,000 McDonald's workers. And they don't want to be embarrassed by bad things happening. They want to see some good things happening. So that makes me think that they might be willing to be flexible. Yes?
I'm interested in kind of the brain drain we're seeing now and we'll continue to see with physicians. I think it was Mr. Miller that alluded to the Medicare physician payment cut. If they're not going to get paid anything, who would want to be a doctor anymore? And how are we supposed to fix that? How are we supposed to have more doctors?
Anybody want to take that one?
Let me take a shot at it. Now, I honestly think that one of the most serious problems facing the country is the demoralization of the medical profession. Physicians are dispirited. Many of us have an opportunity, and it's a great privilege for me to have an opportunity to address and talk at professional medical meetings where members of the medical profession are gathered, and they talk among themselves a lot about the profession and how they can function in this environment. The environment for independent medical professionals is becoming increasingly hostile. You're expected now to go to work for a hospital. You're expected to join a large group practice. At the same time, you're expected to absorb a massive number of people who are going to be getting care under Medicaid. Medicaid, really, if you want to talk about the big change in this bill in terms of insurance coverage, roughly half of all the people who are going to get health insurance are going to get them through Medicaid. Talk to physicians, for example, about what that means. It means that every single time the patient walks into the room, the patient is going to incur a financial loss. It also means that more and more people are going to end up in hospital emergency rooms. This has been completely overlooked in this past healthcare debate. The degree to which Medicaid is a driver of hospital room overcrowding. So I think the situation is very serious. Now, the only way to really change that, it seems to me, is to change the fundamental underlying financial structure of our health insurance system, where we basically have an opportunity for people to buy the health insurance which is best for them and enter into the kind of relationship with a physician that used to be the norm. What I'm saying, in effect, is pretty radical here. I'm saying that what we ought to do is we ought to make one of the goals of healthcare reform the restoration of the traditional doctor-patient relationship for those who want it. Not all people want it, but many of us do. And that's why the president has spent so much time saying in forum after forum that if you like your relationship with your physician, you will be able to keep it. The problem that you and I are we're stuck with is that you may want to keep your relationship with your doctor, but your doctor may not be able to keep his relationship with you.
Well, I think the goal is a one-to-one relationship between the physician and the patient, and we're moving toward that ratio. You'll just be your own physician now.
Let me just say that Dr. Burgess is here with us today, and Douglas Holt-Seacon tells me there are 20 physicians in the House of Representatives. Is that correct?
Of the bit over 80 new members in the House, 20 are doctors.
20 of the new members are doctors. I hope we'll hear from all of you in the debate that starts later today.
Doctor, that just tells you how hostile the medical practice has become, that we seek refuge in the relative calm of the United States Congress, where the problems are solvable.
And we're glad to see you there. Yes, sir.
Doug, you mentioned a couple of new entitlements, one of which is the Class Act. how it's no requirements for reserves. They have 2 protected classes that only have to pay $5 in premium, while others got to pay $240 to make that up. Can you talk about the sustainability of a program like that?
So the Class Act is a new long-term care insurance program whose basic structure on paper is pay premiums in while you work. It looks like a payroll tax. Once you pay for 5 years, you're eligible for benefits. We've seen this kind of structure before, Social Security, Medicare. They're in deep trouble given the way they're structured. And, just to quote someone who would know a lot about this, Senator Ken Conrad, chairman of the Senate Budget Committee, called it a Ponzi scheme. And I think that's an optimistic read because the way the program is set up, it looks like it will have enormous amounts of adverse selection so that the people who actually want to claim benefits will have well above average costs. The premiums will become nowhere close to paying those full costs, and we'll get into what in the private sector would be a death spiral, but the only way, the government never lets death spirals play out, so they'll just be shoveling ever much more general revenue into it. And so this is, I think, on the sort of quality of the policy, one of the worst parts of the bill, and not one that I see any way to redeem. So if you get back to the question, do you try to fix this or do you just repeal? You just got to repeal the Class Act. It's utterly unworkable and dangerous.
The surprising thing about it is that we have this commission set up by the president to tell us what to do about unfunded entitlement programs, and then we pass a bill that creates another one.
I will point out that the Bowles-Simpson Commission, the president's own commission, in its final report recommended repealing the Class Act. So there's, I think that's a very, very telling recommendation coming so quickly after the bill came out.
Yes, sir.
One of the debates that Congress has had over the last few years has involved earmarks, and one of the arguments is that lobbyists come up and get special treatment for somebody for an earmark. Now we have hundreds of waivers being sought through the Department of Health and Human Services. Is this another prescription for political favoritism in the granting of waivers, much like we've seen in perhaps the corrupt practice with earmarks?
I find this incredibly troubling. I mean, the 220-odd waivers we've seen already, first of all, I think are prima facie evidence of the unworkability of the law. I mean, it just simply cannot be implemented as written. But more troubling is you cannot figure out the grounds by which these waivers are being decided. And they can affect the competitive balance within industries, waiving these insurance requirements for some employers and not others. There appears to be no particularly transparent process by which large groups could get a waiver simultaneously and keep competition fair. So I consider this one of the really troubling aspects of the implementation of the law.
I'd like to second that. We have time for one last question. Anybody want to ask it? Yes, sir.
I was curious your thoughts on some of the delivery reform aspects of the bill, including the Center for Innovation and also some of the, there's been a lot of focus on coordinated care through ACOs and health homes, and I was curious whether you think that focus is good, and if so, can a consumer-directed approach deal with those issues?
All right, coordinated care, managed care, evidence-based medicine, pilot programs. Is any of this going to work?
Randomly, yes. In an organized political fashion, no. If you throw enough ideas and money at something, a few things will seep out. However, it's organized in a way which tends to stunt innovation because you don't have the type of feedback loop with real parties determining what works and what doesn't. So you're trying to manage this from on high and thinking that you're calling it innovation. Can you get some incremental gains? Sure. We also have markets, though, with incentives, with people actually spending their own money, which is the fastest route to innovation.
And I want to second to that in one brief way. I mean, the fundamental problem with our government health programs is that we send the message to consumers that they can have all of the highest quality care they want at no cost. And when that turns out to be expensive, we tell the providers, cut it out. Stop charging so much, and they crank down. We demonize doctors. We don't pay them. That's why they're discouraged. You can put all the ACOs you want in the middle of that. Until you break that fundamental mismatch between the promise and the capability, it's not going to work.
Here's the last word. For 25 years, we've been doing pilot programs and experiments in the field of education, trying to find out what works so everybody can copy it. For 25 years, it hasn't worked in education. It's probably not going to work in healthcare. Thank you all for coming.